Okay, I think we'll start with some housekeeping and some introductions. Thank you all for being here. I know people are going to continue trickling in, and as always, we record these webinars. And so if you miss anything, we can, you'll find our recording on our website. So just to introduce myself, my name is Ada Moses. I'm a doctoral student in clinical psychology at Northwestern University Feinberg School of Medicine, and I work part-time as an advisor to the CEO of Let's Talk Menopause, which many of you know is a national nonprofit changing the conversation around menopause to ensure women get the information they need and the healthcare they deserve in midlife and beyond. Our menopause talks are central to our education efforts, and you can find recordings of all of our talks over the last 2.5 years on our website. We'll be putting links to things like that in the chat throughout the webinar. Just a reminder, all menopause talks are intended for informational purposes only. These are not a substitute for professional medical advice, diagnosis, or treatment. We'll be talking about mental health throughout this talk in particular, which may bring up concerns about your own experience. And we ask that you please talk to your doctor about any questions or concerns that you may have that emerge during this talk. A couple more housekeeping items. Before we get started, we have disabled the chat and will only be using it to provide you with relevant links or PDFs of certain things we're talking about. Please ask your questions in the Slido app. You should see a prompt on the right side of your Zoom screen inviting you to participate in Slido. There will be a very brief survey at the end of this talk, and we ask you to complete it so that we can improve our offerings, continue to, offer talks that are of interest to you and that speak to your experience. Now to introduce our wonderful presenters, who I know very well. We all worked together a handful of years ago, and they work very closely together. So you guys are in for a wonderful talk. To begin, Dr. Lisa Weinstock is a New York-based psychiatrist in private practice with a focus on women's mental health during key reproductive transitions. Donna Klassen is the co-founder and CEO of Let's Talk Menopause. She is also a licensed clinical social worker with a private practice and expertise in the field of reproductive mental health. So let's begin by defining a few terms. What is menopause and perimenopause? Some of us probably have been talking about this forever. Maybe for some of us, it's newer. Donna, can you start, help us understand these concepts?
Sure. So when we talk about menopause, we often talk about it as like the menopause transition, so we can use the term broadly. But technically, menopause is really when a woman's ovaries are no longer functional. There's a decrease in estrogen and progesterone. And technically, it's 1 year from when you don't have your period. Okay, so it's like 1 year post not getting your period. It's a little specific, but really what we often talk about is the fact that perimenopause, which is the 4 to 10 year period before your last period, is usually the time when there's a lot of shifts in hormones. And you can look at this graph right now and you can see how all these body parts are affected by estrogen: your bone, your brain, your breast, your colon, your eyes, your heart. And you see those fluctuations right there. That right there is when we have a lot of symptoms, both physical symptoms and mental health symptoms. And that age of 51 is changeable, right? So that's the average age of your last period, but people can get it early, people can get it at that time, they can get it late. But that time of late perimenopause is a time where there's lots of symptoms, there's lots of fluctuations.
Great. And Dr. Weinstock, can you walk us through the connection between perimenopause and mental health, which is our topic today?
Sure. So one way that I like to think about it is there are kind of 3 distinct avenues by which that transition through perimenopause and into menopause can impact our mental health. The first has to do with the hormonal fluctuations and changes that happen both during perimenopause and menopause. Second has to do with physical symptoms, and the third has to do with life stressors. So in terms of the hormonal fluctuations, we know, as Donna was explaining before, that perimenopause is a period of time where you have rapid, sort of unpredictable fluctuations of female reproductive hormones, estrogen and progesterone, which are determined by fluctuations of hormones in higher levels of the brain, like the pituitary and the hypothalamus. And menopause, you just have basically much lower levels of estrogen and progesterone. And we know that the female reproductive hormones, particularly estrogen, impact lots of areas of brain functioning, not just the reproductive tract. And so they do impact the parts of the brain that are in charge of managing mood and anxiety. So estrogen has impacts on the neurotransmitter systems associated with things that people have heard of, like serotonin or norepinephrine. Estrogen impacts the way those things are metabolized and the way those things are produced. And so we sort of think that these fluctuations and these unpredictable fluctuations can impact mood through the way that they're related. And so you have these hormonal shifts, and those are leading to mood symptoms in some women. Unfortunately, we're not really at the stage where we can exactly pinpoint all the ways that estrogen and progesterone impact all of our mood centers in our brain. So we can't exactly determine who's going to develop mood symptoms and who isn't. But we do know that there are certain subsets of women who seem to be more vulnerable to these fluctuations. And we're going to talk about that in a little bit. Then the second way that perimenopause and menopause can impact someone's mood is through the actual physical symptoms that happen as a result of particularly these estrogen fluctuations and then drops that happen during perimenopause and menopause. And so as was on the other side, I don't think we have that slide yet, but oftentimes women can complain of lots of physical symptoms, things like hot flashes or vasomotor symptoms, which are hot flashes, joint pains, achiness, difficulty sleeping, low libido, vaginal dryness. These are all physical symptoms, but those physical symptoms themselves can impact your daily functioning and your quality of life, and that can sort of feedback and then have a negative impact on your mood and your level of anxiety and things like that. And then the third way that that sort of transition can impact our mental health is through the life stressors and changes that happen at that point in time in life. So this is a time in life for many women where we've heard the term sandwich generation. They're often dealing with elderly parents who are struggling or kind of at the end of life or having to help manage those parents. For women who have children, their children are often leaving the nest, and that's a different kind of loss, and that can be stressful. Also, it's a time of life where women will often say they sort of feel invisible because of the way kind of our society views women as they are aging. And so how does that impact them in their job or in their relationship? So these are all kind of like the external things that are happening in their lives, and those can impact someone's mood and functioning too. So there's kind of those three ways that we like to think about it.
Right. So we have kind of a trifecta of hormonal implications, physical symptoms that then make us feel not good, which can increase our mood and anxiety symptoms, and then these life stressors, so these external social pressures or experiences. And we're going to be talking more about vasomotor symptoms in particular and how something like hot flashes might impact anxiety, which is, I think, a really great example. But you mentioned, if you're not sleeping, right, if you're having trouble sleeping, that's going to increase your anxiety and might increase also, sadness, depressive symptoms. So it's this feedback, right? And we'll dive into it more in depth, but it's such a fascinating, interconnected situation. So, these are a lot of these experiences you mentioned are very common, these stressors. Are there certain risk factors that make certain people more vulnerable to experience mental health issues during this time? Dr. Weinstock, I'm wondering if you can speak to this because you mentioned earlier that there's some vulnerabilities that some people might have.
Right. So this slide it sort of talks about it to a certain degree, and sort of more generally, I like to think that there are a number of groups of women who may be more vulnerable to developing these kinds of mood and anxiety symptoms during perimenopause or menopause. So first of all, women who've had prior histories of an actual depressive episode at any point in their life seem to be at higher risk for recurrence of an episode like that during perimenopause or during menopause. And there's actually one study looking at that illustrated that women may be compared to women who did not have a depressive episode, women who've had depression in the past, as they go through perimenopause and menopause, may be more than twice as likely to develop another depressive episode. So we want to remember that women who've struggled with depression are at higher risk. More generally, and I think we have that on our slide, women who are sensitive to other periods of time in their life where they've had these female reproductive hormonal fluctuations. And again, we want to remember that female reproductive hormones fluctuate normally throughout the menstrual cycle. So it's not fluctuation per se, but during different points in times of a woman's life, the fluctuations are different during pregnancy, postpartum. If someone is going through infertility treatment, those hormonal levels are changing in a different way. And there's a subset of women who seem to be more vulnerable to developing mood and anxiety symptoms in the week before their period, postpartum, when they're getting infertility hormonal treatment. And so those women may be at higher risk for, again, developing symptoms during perimenopause and menopause. We also know that perimenopause seems to be a period of time of increased risk of mood problems compared to menopause, as Donna said, the period of time where you've already been done with your period. Right, postmenopause, sorry. And that probably has to do with the fact that postmenopause, you kind of have this even low level of hormones, whereas perimenopause, your hormones are kind of going all over the place as your brain is trying to get your ovaries to ovulate and it's not working. So everything's kind of going haywire. And so it does seem to be that women during the perimenopause are at higher risk. And then finally, women who've gone through a surgical menopause, and those are women who may have had like a hysterectomy where their ovaries were taken out. So if you have your ovaries taken out, you kind of have a rapid, abrupt change in your hormonal milieu, as opposed to perimenopause, where it's kind of going in this wackadoodle way until it stops. And so for those women where they have this rapid, abrupt change, they seem to be at higher risk for mood problems, probably because they have such a dramatic drop. It may also have to do with the problem for which they needed to get that surgery. But those women have much higher levels of physical symptoms and mood symptoms. And so we want to keep an eye on those women as well.
Yeah. Yeah.
I also want to say, can I just add to that a little bit?
Yeah, definitely.
Because there are windows of vulnerability, right? And, but, I know in my own experience with myself and also with my friends, because I'm in that age where everyone's talking about menopause, that a lot of times some other people have symptoms of some of these things, but maybe not have like a big like mood disorder. Like, it's not really, completely getting in the way of their life, but they're really like, they're irritable. They're, they're not feeling like themselves. So just because you're vulnerable does not mean that you might not have symptoms during this time. And also you might not have symptoms, right? I think one of the things is to sort of be like, going into this time is a time of anxiety and you don't know what it's going to look like. Right. And
I think, that's like such an, sorry. Go ahead.
Yeah, go ahead.
No, I was going to say, I think that's such an important point to sort of distinguish between us as clinicians saying there might be some people that we want to, that we're more worried about, but we don't know that means, you can be worried and somebody can sail through menopause. And then you can have somebody else who really never struggled with any significant mood changes. And then their symptoms lead them, or they become more anxious or more depressed. So, that's, I think, what's helpful about talking about this is that, there's not one algorithm or one recipe, but we do know that there are certain things that might make us more vulnerable.
Right. When we talk about risk factors, these are things that we want to be aware of and have people have the information to make choices. But it doesn't mean that just because you don't have some of these risk factors that you might not see an uptick in these mood and anxiety symptoms during this time. I also love this framing of window of vulnerability. And I know at Let's Talk Menopause, we talk about this a lot, both as a window of vulnerability and a window of opportunity, right? And these two things can be true. So both the idea that we can be more vulnerable to experience mood and anxiety issues during this time, and that it can be an opportunity to get care, right? So for some people, they may have never, interacted with mental health care in their lives. And then menopause is a time to actually change that, right? An opportunity to feel a little bit better, to attend to some of these symptoms that maybe you had for your whole life, or maybe they've gotten worse now. But I like thinking about window vulnerability and opportunity together. And we definitely see that in the literature when you read about perimenopause and menopause. So this really brings us to this topic that a lot of us are interested in, which is care, to receive care for mental health. How does someone know if they need care? I think this is a question that a lot of us have. And I'm curious, Donna, can you help us understand it? How would you know if you should reach out and when to reach out?
I think that the main thing is when it's getting in the way of living your life the way you want it to, right? Your work life, your family life. We often hear people saying, I just don't feel like myself. I'm really irritable more than usual. Irritability and rage, I would say also, like people feeling really, really angry and sort of feeling like, what's wrong with me? I've never been like this way before. Not enjoying what you used to enjoy, crying for no apparent reason. Sort of like we call that like lability, like emotional irritability, right? Where it's sort of like you're happy 1 minute and then all of a sudden you're crying, feeling really overwhelmed. It's going on. It's not just this transient thing. It's going on for a couple of weeks and you can't really seem to get out of it. And your usual coping mechanisms are just not cutting it anymore. But I really want to stress that no one can make the decision for you. If you're not feeling well, if you're suffering, you need to it's really important. We want you to find care. You know, oftentimes we suffer and it's really, unnecessary. There is help, and often just talking about it, even with your friends and family, can be really helpful because it that shame just sort of leaves and it becomes easier and easier the more you talk about it. So yeah.
Right. The normalization of it can even be a step in getting care or feeling better. Yeah. And I think that's part of our goal of our menopause talks, right? To gather here together. And even if we're on Zoom, and I wish we could have everyone's voices here together, right? And talk about your individual experiences. And we try to do that to some extent through Q&A, but just knowing here that we're sitting with a group of right now 130 people who have their own lived experiences, it's normalizing and really destigmatizing, I think. So let's talk specifically about some treatment options. We're going to focus on 2 today, even though there are many others. So let's talk specifically about skills-based therapy and psychiatric medication, which are 2 of the things you 2 specialize in. Let's begin with skills-based therapy. Donna, what is it? What is skills-based therapy?
I want to take a step back too, because we will talk a little bit about hormone therapy. But
Yes.
it's not going to be the focus of it. We do have other menopause talks where we do talk about hormone therapy, but hormone therapy can be really effective with moods. We don't want to say that we're not going to be talking about that, but given we only have an hour, we wanted to focus on these 2 things.
Right. We'll focus on these 2 and we'll end with hormone therapy because it is so important to this puzzle. But we'll dive into these 2 because of the nature of this talk, and we have many others that focus on hormones.
Yep. So many of you have heard of CBT, which is cognitive behavioral therapy, and there are some outgrowths of that type of therapy, which is DBT, ACT, mindfulness-based CBT, and we call these skills-based therapy. I kind of lump it all together because as a clinician, I kind of use a mishmash of all of them, depending on who I'm working with and what makes sense. And we have a lot of and we also have a lot of scientific data showing that it helps people feel better. So it is evidence-based. And it's different from what therapy used to look like. If you haven't been in therapy before and you're worried that you're going to go sit on a couch and someone's going to not talk to you in return, that's not what this is. I know as a therapist myself, I'm very interactive. We talk together and we kind of come up with what makes sense for you. So it's a little bit more goal focused and it's skills based. So it's really a little bit more in the here and now. It's more interactive. And it's typically shorter in duration, but that being said, some people really love it and love to sort of continue with it, and it can really help. So this is something that, oftentimes people see one model of this that has 3, but we added bodily sensations in there because this is what I'm seeing with a lot of my clients that I see, is that the bodily sensations, what was going on with your body, often trigger and affect how you feel, what you do, and what your thoughts are. So if you look at this as sort of like your thoughts impact your behaviors, impact your body sensations, impact your emotion, but you could really go any which way, right? And so sometimes, you have a thought like, what if this is going to happen? And your body gets really tense and tight, and then you feel really anxious and nervous, and then you are scared and you withdraw, right? So that's just sort of like a way to sort of frame it. And what we do in CBT is we kind of break that up a little bit, okay? And so I can get into it more, but I think that's sort of like an overlying of what CBT is.
Yeah. And I think I love this image, and we can use this for so many things. And Donna will return to this and we'll kind of use it with some examples, but right, you people, right, that are on Zoom, we could all place we could place things on this cycle, right? So you can imagine what Dr. Weinstock mentioned earlier. You have a bodily sensation like a hot flash. What emotions is it bringing up for you? What thoughts is it then bringing up? How's it impacting your behavior, right? If you experience a lot of intense sadness, what thoughts are you having? Behaviors, is it hard to get out of bed, right? So we can see these interconnected phenomenons in our own lives. And I think this is a really core pillar of CBT is the way that these are all connected and how we can better understand them to then target the places where we're struggling. And I know this is core to my work with my patients, and Donna, definitely to yours. In you, when you're not running Let's Talk Menopause, you do see individual patients in your private practice. Can you give us an example of the kind of things that you work on with your patients that are coming in during perimenopause and menopause?
Sure. So I'm going to use hot flashes as an example because I think it's really important. I think it's helpful. And I think if you think about it, hot flashes and panic attacks look alike, and it's hard to distinguish between the two. And so oftentimes it's, someone's having a hot flash and it leads to feeling like they're having a panic attack. And that sort of anxiety increases, and the anxiety symptoms of your palms sweating and getting really hot happen, right? So somebody might come into me and say, with frequent intense hot flashes or like power surges, and they're twitching, and they're really frustrated by them. They're distracting. She has all sorts of anxious thoughts about them, thinking like, what's going on with my body? What is this, right? And so one of the skills I work with is labeling. Labeling seems like a very basic skill, but really what it does is it tells you what's happening, right? So you kind of put it outside of yourself. So you say like, I'm having a hot flash right now, right? And what that does is it kind of helps you to look at it instead of sort of being like, oh my God, what's happening to my body, right? And there's a little bit of acceptance in that, because oftentimes some people are having a hot flash and they're going like, oh my gosh, this is so awful. What is this? This is never going to go away. What am I doing? How this is going to continue forever, right? And so acceptance, just so people understand this, acceptance is not saying that you're not necessarily going to treat your hot flashes long term, right? It means, what do I do in the moment to help myself feel better, right? We can both treat our hot flashes long term, and we can do things to help them in the moment, right? So fighting that hot flash in the moment will only make the hot flash worse, right? But accepting the hot flash and sort of letting you ride the wave of the hot flash. Same thing with an anxiety attack. You ride the wave. We teach people how to not fight anxiety attacks, although I know it's so hard for people, right? But it really, really, really does help. And labeling reduces the fear around the hot flash. I know what this is. I know I'm having a hot flash. It builds a little bit of distance from it. Right. And then you just say, like, what do I need to do right now to help myself? Right. Oftentimes when you're having a surge, a power surge, a hot flash, you need to move. Okay. So I'm just going to get up and I'm going to move and I'm going to ride the wave. You're riding the wave. What do I need to do? And I know this sounds like, it can sound silly to people, but it really does work. Changing the temperature works. We know this. We know this. If you put ice in your hands, it actually tells the body that there's danger somewhere else, and the brain goes to that versus what's happening in your body, right? So, and especially with hot, you get hot. With anxiety, you get hot. So going and splashing cold water on your face and riding it out, right? And again, this acceptance in the moment does not mean that you're going to not accept it, that you're not going to advocate for yourself and work to get treatment long term, if that makes sense.
Right. So acceptance, and I think this is a really confusing thing about the word acceptance. We use acceptance in therapy all the time, but it doesn't mean throw up your hands and say, I'm going to struggle through my hot flashes forever. I'm having really intense hot flashes. I'm suffering. I'm not going to do anything to change it. That's not acceptance. You could be working with a provider. You could be taking hormones. You could be really facing these hot flashes, working to get them, more manageable, while also accepting them in the moment when they occur. So acceptance does not mean, I think what we often confuse it with what, like
giving up, but that's not what it is. Yeah, that's not what it is. It's actually like accepting your feelings in the moment, fully accepting them, like owning your feelings, owning what's happening, really accepting it, and then kind of letting go. It's a relief, right? Of sort of just like, I'm going to let this go right now. It is what it is in this moment. I can't change it, because we do know that fighting things, like fighting anxiety, only increases anxiety. Fighting hot flashes only increases hot flashes, right? And so it's counterintuitive, right? Because you feel like, oh my God, I want to fight this. I want this to go away. But really in that moment, all you can do is accept it and then figure out, what can I do? Because that gives you power. What can I do right now to help myself feel better in this moment? Because that's what I can control.
Can I just say something which I think it's kind of brings a lot of this together? Also, there's another term that we use a lot of times when we're talking about this type of therapy, which is psychoeducation. And I think what the labeling and the acceptance are all part of as it relates to this kind of scenario is that because we know that we all are hardwired, whether we're in menopause or not in menopause, whether we've had anxiety before, that when we have, as Donna said, certain anxiety provoking thoughts, we will get physical symptoms. And then the physical symptoms feed back in our primitive part of our brain to make us more aware, which is a good thing in some scenarios, but not in all. And so in hot flashes, there really isn't a lot of value necessarily to having the hot flash, but the symptoms that you have overlap with symptoms of anxiety, and they can sort of spiral into like that panic attack. And then the anxiety that comes along with that spirals it. So when you can label, when you can stop, it's not even so much, you use the word fighting, but it's kind of like addressing, you know what I mean? When you're sort of taking control and you're acknowledging that this thing is happening, but there are better ways than sort of letting that spiral continue. And all of these are skills that slow us down and help us do that. I think that's really important to remember.
And I think if you're sitting here in the audience thinking like, that sounds great and all, but I couldn't do that right now. That's why skills-based therapy is a process, this being able to gain the words for it and grow distance from the hot flash, name it. And kind of, as Donna and Dr. Weinstock are speaking about, kind of ride through it. These are things that take time. You work with a therapist to get there. So I think this is, it's not something that we do in a second. It's building up those skills, which is why we call it skills-based therapy. So yeah, and if you're a provider in the room, you know how this can look, right? You know how patients get there and what it takes to get patients there. So Donna, there's a couple other, I think there's a lot of pieces to this that are interesting. I'm wondering if you can give us another example, and specifically I'm thinking about thoughts, like how do thoughts come in here?
Mm-hmm. So I'm going to give another example about somebody having difficulty word finding. So we do know that cognitive changes in perimenopause and menopause happen. I know they've happened for myself, and they can be really distressing, right? So all of a sudden you're at work, you're giving a presentation, or you're talking to a colleague, and you cannot remember a name of something so basic and so something that you used to be fly right off of you, right? And so what often happens is what we see is that people then think, oh my gosh, like what if I have dementia? What if I'm developing Alzheimer's? What if I can't work anymore? I'm going to lose my job. Nobody, I'm not myself, right? And so, and also saying like, this is only going to get worse, right? And so that's where going back to that, like, how your thoughts impact your mood, right? If you're sort of saying those things to yourself, of course, you're not going to feel good about it, right? And so here's where I sort of draw on a bunch of different tools, and not in particular order, and it really depends on the feeling. One is to get people to start thinking about their thinking, right? To think, it's called metacognition, right? And so like, what are these automatic thoughts that I have? Right. So oftentimes in the first few weeks, I will have the person write it down. Like, what are you saying to yourself every day? Right. Because that's really important, right? What you're saying to yourself impacts how you feel, impacts what you do. And so what are those?
I just want to pause on that to make sure everyone heard that, because I think it's so crucial to CBT to think about your thinking. These automatic thoughts can be so automatic that we often need to pause and actually write them down or vocalize them to, a loved one or a therapist to say, oh yeah, I am having the thought daily, I'm going to die from this, or I have dementia, right? So these drawing attention to the thoughts. Okay, so that's one of them. And what's another tool?
So here's sort of where we talk about labeling, right? So it's a big difference to have a thought, right, that says, oh my gosh, I have dementia. I know I do, right? Your body then reacts as though, it's like your body's going into panic mode, right? It's sort of like, oh my God, I've got dementia, right? Because it believes it, because it thinks like those thoughts are facts, right?
Well, you're saying it like a fact. I have dementia sounds a lot like a fact.
It sounds a lot like a fact, right? So that's where getting people to slow it down a little bit. And I actually will do like exposure to the thought, right? And I will say people, okay, rate your anxiety from 1 to 10 when you have okay, what if I have, I'm going to have dementia, right? And they're always like 10. Right. Oh my God, that's a 10, right? Or whatever it is, right? Whatever that thought is, or so many anxious thoughts that people have, right? But if you say, I'm having an anxious thought that I'm going to get dementia, that sounds a lot different, right? And so that's where the labeling sort of takes it out of you, right? And you say, I'm having an anxious thought that, right? And then I'll actually do an exposure, right? So exposure is a treatment for anxiety, exposure to doing things, exposure to, you know, like if you're afraid of flying, we wouldn't say to you, okay, don't fly, right? We would say, let's work on getting you to fly, right? Because that actually decreases anxiety. But what labeling does is it takes it down. And oftentimes I'll do exposure and have them say it 10 times, right? And to say, I'm having an anxious thought that, that I have dementia. I am having an anxious thought that I have dementia. I'm having an anxious thought that I have dementia, right? And by doing that, it sort of takes the power away from the thought, right? So it reminds us that our thoughts are not facts, our feelings are not facts, and it reduces anxiety. The other thing that I do, and again, the other thing that I will say, right, is I will not say to people, right, that we don't know what's going to happen, right? So part of all of this is tolerating the unknown in life. There's a lot of uncertainty in life, and one cannot say what somebody's going to have and what, they're not going to. But in that moment, what is that doing for you? Because you're not living your life in that moment if you're only thinking about what's going to happen in the future, right? The other part in there are these unhelpful thinking styles. And we are going to hand that out to you in our quick tip coping skills. We're not going to have it up here, but there's a lot of unhelpful thinking styles. We all do them. But when we get more anxious and depressed, we often do them a lot more. So some of those things are all or nothing thinking if it's only one way, or, if it's not that one way, it's bad. Another one is catastrophizing, the what ifs, like what if I have cancer? What if I have this? What if I have this? Disqualifying the positive, like saying like, oh, that doesn't count. Mental filter, which is only looking at certain types of evidence, like only looking at like feeling badly for the last 2 days, but not looking at the whole week. And that maybe you had good moments and good times and good moments of joy in there, right? Another one that's real, I see a lot of, is predicting the future. So it's sort of like, I'm always going to feel this way, right? I'm never going to feel better again, or I don't know if I can go to that because I don't think I'm going to feel well. So you're sort of predicting how you're going to feel in the future. And so what we do there is I give a handout of those unhelpful thinking styles. And just like thinking about your thinking, it's also thinking about when are these unhelpful thinking styles coming up, right? And just to notice them, not to change them yet, but just to notice them, right? And I can go on and on of sort of like the other skills I do in there, right? But it's also a little bit of self-compassion, right? And I always kind of hate the word self-compassion because it feels a little hokey, but really what it is like, I'm being really hard on myself, right? That's self-compassion. Or, oh, I'm having a really hard time right now. That's self-compassion, instead of being so judgmental about what's going on, right? Yeah. I'm so irritable. I'm such a, I'm such a bitch, like I'm a bad person, right? Instead of saying like, oh, I'm having a symptom of irritability. Right.
Can I just say one thing? Like, I know Don and I, you and I have talked about this a lot because I have word finding difficulties too. And we always talked about like, it's really embarrassing when you're sitting there, you're trying to come up with words and you know it and you can't. But the other thing is that even for those of us before we've kind of gone through this stage of life, we have word finding difficulties from time to time. But what happens is, if you're, for a lot of us, if you can't think of a word and you say, I'm just going to stop thinking about it, and you go to something else, in 1 second, it comes back to you, but you're past that. And so what's stopping you in that other scenario, when you start to think you have dementia, is you're adding in anxiety about having dementia or not being able to speak. And so when you do what you're doing, not only does it bring down the anxiety in general, which just helps, but actually helps the problem often, not always in the moment. And you've talked about this even in terms of giving talks. Like if you can't think of something, just stop and say, I can't think of the word for that right now. It brings everything down. You might think of the word then, but either way. So it's again, that idea of how the spiraling, how the anxiety plays into standing in the way of our cognitions or standing in the way of our physical experiences, and you're kind of breaking that cycle, which helps.
Acceptance.
Yeah, and I think it's really important to say, like, if you're having a hot flash or if you're having word finding issues, just say, like, I'm having a hot flash right now. It's what Drew Barrymore did on live TV, right? And it was amazing. Everyone was like, oh my gosh. Same thing with word finding, like, oh, I'm having trouble finding that word. Can someone help me out? Yeah. Or like, and by doing that, it just sort of takes the pressure off. It takes that, instead of that pressure to be perfect, instead of that pressure to always know what you're doing, it makes you human, right? And more relatable. And you'll find that people will open up to you and say like, oh, I have trouble too. And oh my gosh, I have that symptom too. And then people feel better, right? So just labeling it actually in that moment. And I often do that even when I'm talking, because oftentimes I will lose words.
Totally. Like even you're hosting a talk and we lose words. It's just what happens, right? And then people experience it in important board meetings, right? And speaking in front of hundreds of people. We know this, right? And a lot of people who are going through perimenopause and menopause have big professional lives. And so these word finding difficulties, these hot flashes occur in professional settings. And we've done talks that are more particularly about this in the workplace, but these are skills that you could bring into even these high stress or high power professional moments. I also did want to just mention one more thing to Donna's point about self-compassion. It is so difficult. And one of the skills in CBT that can sometimes feel more approachable is not, if we can't even imagine being kind to ourselves, right? If we haven't yet worked up this self-compassionate voice, sometimes I just even ask patients, like, would you speak that way to a loved one? And if we ask ourselves, how would you say that to a friend, right? If when your friend forgets a word, do you say to her, you're the dumbest person I ever met and you're probably going to die from this? No, you probably say, oh, it happens to the best of us and the word will come to you, and so how differently are we speaking to ourselves than we are to friends or family? And that can even begin to, again, make us notice our thoughts, make us notice how we're speaking to ourselves, and to work to speak to ourselves in a way that's much kinder that we would to someone that we care about.
And I will say that, CBT used to be a little bit more like to sort of change those thoughts. And I would sort of argue to say that really it's more about noticing, and the change sort of happens a little bit more gradually than that, by other things that we do. So I know that it's a lot to put into a short period of time, like what I do with CBT and what other people do with CBT. I can just say that I'm find as a therapist that I find it much more helpful. I'm not bashing other types of therapy, but I just think, with this, especially because perimenopause has so many physical symptoms, that it really changed the game.
Totally. And we could talk about this forever, the three of us, right? We love this stuff, and I think we're going to shift in a moment, but this is so important, and we can do more talks on this. And a lot of what Donna has talked about is really there are waves within CBT, think feminism, first wave, second wave, third wave. We have similar things with schools of thought, and CBT has first wave, second wave, third wave. And a lot of what Donna's talking about is acceptance and commitment therapy. So for those of you who know about it or are interested in learning more, acceptance and commitment therapy brings in a lot of this stuff around acceptance, around mindfulness, around not necessarily kind of changing the thought, but how do you understand the thought and move towards a life that you want to live. So we can do some more content on that, but let's stop on this for a minute and kind of shift to medications, which people might have some questions about. Dr. Weinstock, how do medications fit into this treatment puzzle? We've talked a little bit about therapy. What about medications for mental health issues during perimenopause and menopause?
So medications can be another tool that we can use to address a lot of these symptoms. And we know that certain antidepressant/anti-anxiety medications can help both with the mood and anxiety symptoms that we've been talking about, whether it's like a major depressive episode or an anxiety episode or just symptoms of depression and anxiety. So they help with that. But interestingly, and they help with that when those symptoms are associated with perimenopause and menopause. But they also can address some of the physical symptoms themselves, particularly vasomotor symptoms and hot flushes. And there are some women who choose not to use hormone interventions for that. And so what's nice about some of these medications is that they can work on two of those areas that we talked about before. And so you may have heard of some of these medications, the SSRIs, the selective serotonin reuptake inhibitors, with names like Prozac and Zoloft and Lexapro. We're not going to go through all of them. And then the SNRIs, which are this sort of the second generation, they're the serotonergic norepinephrine reuptake inhibitors, and they kind of work on two different neurotransmitter classes. And those are ones you might have heard of, like Effexor or Pristiq or Cymbalta. And both of those classes of medications, which we use even outside of perimenopause and menopause for anxiety and depressive symptoms, can help for those symptoms in perimenopause and menopause, and can help address some of the physical symptoms. So in terms of the moods, they can help you regulate your mood. They can help slow down anxious thoughts. They can address ruminative thoughts, and they can address the symptoms of depression and irritability. And then oftentimes, if somebody is in like a major depressive episode or has more significant symptoms that maybe coming from depression, like trouble eating or trouble sleeping, or, you know, having low motivation. If we address that with the medications, that will help their quality of life. And this is so key because it kind of harkens back to Donna's work, because sometimes there are people for whom the CBT can be so helpful, but they're feeling so symptomatic that we kind of can't even help them understand that. It's like when you're so sick, you can't even, like with the flu, if you're so sick, you can't even hear what somebody's saying. You kind of need to like get your symptoms under control enough so that you can learn these skills and practice these skills. So we use medications, those kind of medications for all of those kinds of symptoms.
So
And
you're
then
saying, just to be clear, I want to make sure I'm hearing you correctly. So in those cases, you're saying sometimes if people are really struggling, they might need medications to kind of come back to baseline, or to at least, you know, to feel a little better before they can begin doing something like skills-based therapy.
While they're, or as they're doing the skills-based therapy, but the skills-based therapy will help them as they're feeling better. You know, you're kind of increasing the chances, so to speak. You're maximizing their ability to do well, because you're recognizing that, as we've all talked about, the skills-based therapies take time, right? And so you're learning and you're practicing, and not that medications don't take time too, but sometimes they can kind of kick in a little faster and then help you utilize those skills. So we use them for that. And then we also do use them in certain cases just to address some of these physical symptoms, particularly the vasomotor or the hot flashes. We use the SSRIs, the SNRIs. I know we're big fans of using those to help. And then also, there's a medication called gabapentin, which is a medication that neurologists use. It's an anti-seizure medicine. It's a pain medicine. And there's been some evidence that that can help with hot flushes too. And then finally, I'm not going to go into it just because there's too many things to talk about today, but we also can sort of pinpoint different symptoms that a woman might be experiencing and use psychiatric medication to pinpoint that symptom per se, particularly, let's say, sleep. If someone's having trouble with sleep, we may want to utilize some of our other psychiatric medication. I'm not a big fan, we've talked about this a lot, about using long-term sleeping pills for people who are having trouble with sleep. But if you can address people's sleep difficulties while they're addressing these other things, and they're feeling better and they're more well rested, they'll be able to learn the skills better, they'll be able to feel better, they'll be able to eat, et cetera, et cetera. So that's kind of all the different ways that we can utilize the different psychiatric medications to help with these kinds of symptoms.
Right. And I love it. That was a great plug for CBT for insomnia, because, you know, we know that people, you know, struggling with sleep is very common during this time period. And on this note of CBT, there's actually this wonderful specific intervention for people who are really struggling with insomnia called CBT for insomnia. You know, if anyone's interested, you can, you know, read about it or actually ask your providers about it. If we have time, even in a question, maybe we can, Donna, maybe you can speak to it a little bit more. But I think that's a great example where maybe you would be on medication in the interim, right? In the short period, medication to get you sleeping, because we all know it's impossible if you're getting 0 hours over the course of 4 days, let's say. Maybe you would take some medication to at least get some hours, and then really come in with some skills-based therapy to get better, you know, behaviors around sleep and kind of shift your relationship to sleep. So that's a great example of the partnership between medication and CBT sometimes.
I also think that's a great example of what you referred to earlier, that it's both a window of opportunity. So I see a lot of patients for whom insomnia has been a lifelong problem, because oftentimes when they get in bed, that's the time and everything's quiet and they start worrying. And so they've developed bad sleep habits throughout their life, and they've addressed it in one way or another, or haven't addressed it. And now here's an opportunity where, yes, it's like sort of the silver lining of the difficulty, where, you know, they're going for treatment, and the CBT for insomnia, which I'm also a big fan of, is a skill that you can use throughout your whole life. And so it is this window of opportunity to learn that. So I think that's good.
I also just want to add one thing, just going back to skills a little bit, is validation. And I think that, you know, we, knowing that, like, you're not alone, knowing that, like, you know, we hear you and we're listening to you. And so for those healthcare providers out there, and I know you're coming to this, so I know that you do that, but one of the most important things is say, like, I hear you, I see that you're struggling, right? And so being heard and listened to is really important, and to figure out what are the next steps. And so I think that that's also, you know, that's
right. I think that's such an important point, because we can't really do any of this without validation, right? If you don't feel heard by your provider, if you don't feel heard by your friends and family, it's hard to work on these things. And that's, I think, one of the beautiful goals of Let's Talk Menopause is we kind of start from a place of hopefully saying like, we hear you and you're not alone, right? These experiences can be difficult and other things that are wonderful, but can be really difficult, and you're not alone. And we understand that. So before we get into Q&A, because I know this is the type of topic where I'm sure all of you are a buzz, right? My cousin has this, I have this experience. What should I do? What should I take? How should I go about it? And I will say when we come to Q&A, I know there's a lot of desire to get specific medical questions answered. And, we have a wonderful, brilliant psychiatrist here, but because the nature of this talk, we won't be addressing any specific medication questions, about your specific care. But if you have questions for Dr. Weinstock or Donna that are more broadly about mental health and mental health treatment, we will get as many of those answered as we can. And anything we don't get answered, we can also work to answer them via email or via social media. So before we talk about Q&A, before we do Q&A, I do want to come back to one important point that is really a great reason why we have both of you here on this talk today. I'm curious, how do both of you go about recommending treatment for patients? How does someone know where to begin? Should they begin with therapy, with medication, with both at once? I know Dr. Weinstock, you gave us one example of cases where someone might want to start with medication or do therapy and medication together as they're getting better. But Donna, maybe you can open this up for us. How does someone decide who to call first and where to begin?
That's a really good question. And I just want to say to people, we have like 12 minutes left and we want to get your questions. So we're going to be really kind of fast with this. But I do think that, going to your provider that you know now and getting a recommendation and where to start. And if you don't know where to start and you're confused about medication and you're confused about hormone therapy, I think starting with a CBT therapist would be helpful. It's going to be hard to find somebody who knows about menopause because, just regular doctors don't know about menopause, but to sort of do your research in that. But there are many, many good therapists out there. Finding the right one that's a good fit for you. But if you're really, really struggling and you're not sleeping and you're not eating and you have these really intense symptoms, then I would go right to a psychiatrist, because I do think that that's important, and or to your GYN who's prescribing hormone therapy to talk about that. But as we can see in some of the questions, people are afraid of taking hormone therapy. And I would say, let's look at that as also from an anxiety standpoint as well, right? Because it's sort of like a fear of doing something that's going to, get there. So how do you do this benefit analysis?
That might be a great first question. I love that as kind of a first question we'll address, but I'll just let you, Dr. Weinstock, kind of speak to this too. One of the main points we want our audience to hear is there is no one size fits all here, right? There's no one way to do this. So some people might benefit from working with both a psychiatrist and a therapist. Some people might work with one or the other. And I'm wondering if you can kind of speak to that more, Dr. Weinstock.
Right. Well, I will speak to that, but also to integrate the role of the OBGYN, because sometimes hormone, whether it's menopause hormonal treatment or, some sort of hormonal intervention can be a really good intervention to help with some of these symptoms. So sometimes you have a good relationship with your OBGYN, you may want to ask them to, or ask them to refer you to. So in an ideal world, we're all going to be talking with each other. Unfortunately, medicine these days is not always an ideal world, but I would agree with, sometimes you might have a connection to somebody who's a therapist, or have a friend who is a therapist, a social worker, a psychologist. You can start with them, but you would want to start with someone who does know something about this area. Or if you're already seeing a psychiatrist, maybe your psychiatrist isn't as familiar with female reproductive issues, and you can ask, can you refer me? This is a big area, new area of not so new anymore, of psychiatry, which is called reproductive psychiatry, which is sort of the interface of psychiatry and women's reproductive health. So I don't think there's a one size fits all, even in terms of who you reach out to first, but you try to, as best you can, reach out to somebody who identifies as having some expertise in this. Don't be afraid to ask questions. Just because you're seeing your OBGYN doesn't mean you shouldn't bring up what you would consider more psychological symptoms. Just because you're seeing your psychiatrist doesn't mean you shouldn't bring up what you would consider more physical symptoms, because we should all be working together and acknowledge what we can address and can't address. And so that's kind of, I think I would just sort of reinforce what Donna is saying in terms of that.
Definitely. And I did just include two links in the chat. One is for, the second link is on our website to find a menopause informed provider. And we need more people training to be menopause informed providers, but this is a wonderful way to get in contact with someone who, knows a lot about perimenopause, menopause, and postmenopause. I also threw in Women's Mental Health Consortium in New York, specifically looking for therapists who, do focus on reproductive mental health, or often called women's mental health. But let's pause for now on this. I know we could talk about a lot of this in more detail, but we really want to make sure we have some time to get to your questions. Donna, do you want to kind of take it away with some questions?
Yeah, I'm going to take it away with some questions, and I'm just going to say some of these questions were more medical, and I would just refer you back, everyone, to our menopause talks. We have 25 of them on our website. You can go through them. When we have one on bones, we're having an upcoming one on hair loss. But I'm going to ask one here for Lisa. If regular lab work is normal, what other labs should we check that would reveal a possible cause of sudden onset of anxiety?
So if regular lab work is normal, what other? So I typically, when someone has sudden onset anxiety, the lab work that I'm the most interested in is your thyroid functioning, also your blood count, because sometimes when you have low red blood, like when you're anemic, that can mimic symptoms of anxiety, and you want to look at kidney and liver function. So I generally look at that and some vitamin levels and things like that. I mean, there are sort of those red herrings or those zebras that are very, very rare causes of sudden onset anxiety. But I don't think I would go to those kinds of lab work unless people were having other physical symptoms. So, again, we didn't have as much time as we would have liked to talk about what are the physical symptoms that typically go along with anxiety and how do they present themselves. And they are things like your heart beating really fast, or your hands shaky, or now when your heart's beating fast or when you feel chest pain, of course, you're going to worry that you have a cardiac thing. So, depending upon what age you are, depending on whether you have other risk factors, like you smoked or you did smoke or you have diabetes, you might want to, integrate in your medical doctor. But again, I can't think of other than sort of the normal labs, which would be those that I've discussed before, something particular that I've targeted. People ask a lot, I know this, to me and their OBGYNs about like, how do I know if I'm going through perimenopause or menopause? Should I check my hormone levels? And most of us don't think we need to do that because your hormone levels aren't at one point at one particular time. So that's not as helpful for most people. It might be helpful in some women who don't have a uterus, because then you don't really know when they are or aren't getting their period. But for the most part, I wouldn't go into any sort of esoteric labs.
Yeah. Okay, another question for you, Lisa. What if you're not a candidate for an SSRI or SNRI because of serotonin syndrome-esque experiences? Are there other alternatives that address the varied symptoms?
Yeah, so I mean, we talked about before, gabapentin can be helpful. The cognitive behavioral therapy can be helpful. There are other types of mood stabilizers that people might look into. And I mean, there are other types of antidepressants that have anti-anxiety effects. So I think you really want to, tailor it to which symptoms you're having. Another medicine that we use for some symptoms of anxiety is the beta blockers like propranolol, which can help your physical symptoms of anxiety. So perhaps some people will have anxiety in a presentation like this, or if they're a violinist, their hand will start shaking. But if they can get their physical symptoms under control, they're fine. And so for someone like that, we might use one of those things. So again, you would want to talk to your provider and also try to find out why you had that serotonin syndrome, because sometimes that might have been because you were on a combination of medication. It may make sense to even retry that. But I wouldn't comment on that without knowing somebody's full history. So.
I'm going to combine two questions. One person asked about hair loss and how it correlates to menopause and mental health. And then the other person asked about urge and stress bladder incontinence, and it's very stressful. And this is really where your physical symptoms are impacting how you feel, right? And this is why it is so confusing. And we have on our website, we have this menopause puzzle, and we don't even have all the puzzle pieces in there, right? Because it's sort of like fatigue, can be impacted by sleep, but fatigue can also be a symptom, right? And when you're having urge incontinence, and if you're having vaginal dryness, and we call that the genitourinary syndrome of menopause, go on our website about that. It's a new term for this whole spectrum of symptoms. So the person that asked about urge incontinence, I would recommend going to a urogynecologist, somebody that specializes in menopause. And there are a few of our people, the people that are on our advisory board, Dr. Rachel Rubin, Dr. Kelly Casperson, who have amazing information on their social media accounts. You said that, PT did not work for you. So I recommend seeing somebody for that. In terms of hair loss, right? That's also something that like it's stressful, right? And does it impact, I don't know if the question is, does it make it worse, the hair loss, or does it is it the psychological effects of hair loss, or is it, like going back and forth? Do you have anything to add about that, Lisa?
Well, yeah, I mean, the hair loss I think is an interesting one because there are other times in the female reproductive cycle where women get hair loss that may be related to these hormonal shifts. So a lot of times after a woman has a baby, they'll lose hair. And you can have hair loss in cycles, and there are so many things that contribute to hair loss. So female reproductive hormones are one, other hormones are another, stress is another. And so again, they can sort of feed back on each other. So I would say when I have patients with hair loss, even if it's not during perimenopause or menopause, sometimes I'll refer them to a dermatologist who can do a better evaluation of other reasons. And again, I think from the standpoint of stress, we want it feedback. If you're worried about your hair loss and you're constantly, that's going to make you more anxious. Maybe that's going to make the hair loss worse, or maybe that's going to exacerbate other things. And that's kind of what we talked about. It's very frustrating as we go through this sort of stage in life and we're starting to feel older and maybe less classically attractive, and then you feel like your hair is falling out. That can be really stressful. So that's why I think the therapy can be a good part of it too. But you want to have sort of a comprehensive evaluation. I would go to your internal medicine doctor and make sure there isn't a thyroid problem or something like that. If they can't find something, go to a dermatologist, but then also talk to your mental health providers about how to manage and accept that this is the phase you're in right now and how can I address it.
Right. I'm just going to ask two more quick things. One, somebody asked about the new Veoza medication, which is fezolinetant. So that is a new advancement. Somebody else asked about new advancements in medicine. This is not a psychiatric medicine. This is for hot flashes. And so with the new research, we actually found out why women have hot flashes, and I won't get into the details of that. In terms of what we think about it, I know people who've used it, and it's a great option for people, as is hormone therapy. And I encourage people to go through that. Some of the other questions on there, again, were about hormone therapy and being scared to take it. And I would just say to people, it's really important to go to a a Menopause Society certified. You can get it through our website. Somebody who really knows about this and can do a full risk benefit with you about hormone therapy and the relative risk, right? And so many times people are worried about just breast cancer. And as for somebody who has breast cancer, I could just say to you, right? Like there's the data is different. We're looking at it differently. We're thinking of it a little bit more of like long-term and some of these other long-term risks that happen. Somebody asked a question about folks with autism. We do not know that. I will just say that we are really behind on lots of different things. It's a really, really good question. I will also talk about same thing with ADHD. I don't think enough has been done about that. Like people who have ADHD, and does it get worse in perimenopause? I would say yes, personally.
Probably.
My own experience. And somebody else asked about if you started menopause early in like your mid-20s, how does it affect you if you've just been stuck for almost 20 years with these symptoms? And I would say that your timing, unfortunately, was really terrible because of the WHI study that happened 20 years ago. Right now, we would say that anybody who has early menopause would automatically be put on hormone therapy until the age of menopause. But there are things that you can do. Who asked me that question, because I don't want you to feel stuck. You shouldn't feel stuck. You do deserve to feel better. And if you've been experiencing for this long, how can you find providers that can help you through this and that can help you feel less stuck? Because it's a terrible way to feel. And so everyone deserves to feel much better. I wish that we could have answered more of your questions. But
we could do a Ask the Expert with Dr. Weinstock or another mental health provider to kind of dive into some of these. So we know people have more questions than this, and we have other ways to kind of get some conversation going. I do want to be respectful of everyone's time. So I think as people are filling out the survey, we'll let people trickle off, and we just want to say a huge thank you for joining us today, and to both of our wonderful panelists for all of your wisdom and for, starting this conversation for all of us.
thank you.
Thank you. Thank you.